Great. Well, thank you everybody for being here today. All right, we're going to go ahead and jump in. The one thing I did want to share with you is there's just a couple of slides where we address some suicide prevention. And so just want to kind of give that disclaimer up front that if anyone feels like they want to step out for just a minute or something and practice some self-care around that, please feel free to do that. You're more than welcome to. We want everybody to be comfortable today. So, all right, so here are our learning goals. We're going to just chat a bit about the early warning signs in children and youth, understanding mental illnesses and their impact on how it can affect functioning. Again, just touching a little bit on the suicide warning signs. Then we're going to talk about some strategies to help and chat a little bit about local resources. So when we're thinking about behaviors, what we really want to think about is the behavior that we're seeing age appropriate, right? Because there may be a behavior that we're seeing in a 3-year-old that wouldn't be appropriate for a 16-year-old. And so just thinking about the fact that some behaviors are a clear warning sign, no matter the age or stage or situation. And there are certain behaviors that are absolute warning signs no matter what, such as underage drinking, substance use, self-harm, and potentially having suicidal thoughts. Would you like to maybe move a little bit over there? I don't want to stand right in front of you. No, that's great. Okay. No, thank you for volunteering. All right. Okay, so when we're thinking about the fact that not all behaviors are behavior, what do we mean by this? So sometimes if an individual is developing a mental health challenge, they can't necessarily control what's happening in the moment by their own sheer will. Behavior is the language used to communicate that something is wrong. So when we're thinking about specifically children and youth, they don't always have the vocabulary or the words to describe how they're feeling. And so sometimes those behaviors can be a substitute for the language. What's beneath the surface? I really like this slide because as people who have youth in our families, maybe we're serving youth through our vocation, I think this slide really speaks to what we see a lot, right? So behaviors are part of the iceberg, but what's underneath that? And what symptoms might someone be experiencing that would be contributing to the behaviors that we're seeing? So important to note, mental illnesses are brain disorders that affect thinking, mood, feeling, and the ability to relate to others. Medical illnesses, right? Just like a physical illness. But in this case, especially with children and youth, the symptoms may be demonstrated as behaviors. Some interesting mental health facts that folks might not be aware of. About 1 in 5 children in the U.S. experience a mental health disorder, and about half of those children and youth who live with a mental health disorder do not obtain treatment. That's a big percentage. So what would you think would be driving the fact that youth wouldn't get help? There's a few, actually. A few reasons. Financial reasons, absolutely. Yep. Right? Not wanting to talk about it, just the stigma and discrimination in our culture. Access to mental health care. We have a shortage of providers, don't we, in our system? Exactly. Yeah.
Not enough awareness to the problem, because maybe the parents think it's normal. It's not.
Right. Especially for a child or a teenager, young adult, if they're starting to experience the symptom, they're likely not going to automatically assume that they're developing a mental health challenge. They may think it's developmentally appropriate or something that they're supposed to feel, right? So half of all lifetime cases start by the age of 14, and this is connected to puberty and changes that are happening in the brain during this time of life. 3/4 of all lifetime cases have typically begun by age 24. That doesn't mean that if somebody doesn't develop a mental health challenge by their early to mid-20s that they never will, but this is when we tend to see it the most. We were talking about early intervention earlier, and just the importance of that, and what makes it really difficult to diagnose is that, are we seeing these behaviors as a result of something that might be happening in the child's life? So in other words, are they having trouble in school? Are they getting bullied on social media? Did they break up with a partner? Are parents having issues? Is a grandparent ill? We don't know what's going on to drive some behaviors, if they appear sad or they're isolating, or could it possibly be something else? So that's what makes it even more complicated when it comes to diagnosing children and youth with mental illnesses. We know that traumatic stress is a big, big, big one, right? Traumatic events can greatly impact a child's mental health and well-being. And what might be traumatic for one person is not necessarily traumatic for another. We all have different, what we call stress thresholds and stress tolerance. So it can look differently literally for everyone. But trauma can be caused by a host of things: violence in the community, natural disasters. Does anybody down here have friends or family in Florida? Right? Just watching what was going on that part, the state and on that part of the East Coast was really rough. Not to mention the fact that the folks who are living down there who are finding themselves with challenges with food and electricity and just all the things, right? So trauma can be a big trigger. So here's just kind of a list of some of the common mental illnesses that can affect children and youth. We're going to unpack some of these symptoms in just a few minutes here. But you have mood disorders such as depression, bipolar disorder, conduct disorders such as ADHD, which is very common. There's several different anxiety disorders. I love the fact that Kathy Flaminio was talking about anxiety management this morning, because I think we all experience it. And we know that some anxiety can be good, right? Some stress can be good because it propels us forward and can motivate us to do things. But then we have that threshold where it becomes immobilizing and affects our ability to manage ourselves, right? And then we have substance use disorder, we'll talk about very briefly, OCD, and then PTSD. So I forgot to mention at the beginning of this that I'm not a mental health professional. I'm not a licensed, master's level or PhD level mental health practitioner. I'm a certified family peer who brings lived experience to the realm. So I just want to make sure that folks know that. And so when I'm giving this presentation, of course, this is all based on facts, that we get through, SAMHSA and NIH and all those types of things. So the facts are 100% accurate. But if somebody has a really in-depth question about a certain mental illness, I'm not going to be able to accurately answer that, and I won't try to. So I'm happy to get more information for you if you do have a particular mental health challenge that you want more information on. But I just have to say I'm not a doctor. Okay, so yeah. So recognizing early warning signs, how might this look? So being tense and keyed up, maybe difficulty staying seated or sitting still, difficulty keeping hands to self, repetitive behaviors, fear and avoidance of others. So again, thinking about context and age. Are the behaviors that we're seeing something that might be kind of typical for a small child? Maybe. But is this somebody who's 15, 16, 17 years old? Is that going to be typical for them? Some more warning signs: losing their temper easily without much provocation, distractibility, restlessness, difficulty sustaining mental effort. And what we mean by this is maybe we have, for example, a student who can get through the first 5 problems on a math test and then just can't concentrate long enough to finish the test, that type of thing. Blurting and issues with taking turns. Again, this can be related to impulsivity. Inconsolable. So if we have a child or teen, youth, whose emotional response is way beyond what we would consider typical for the situation or what they're experiencing, that might be a warning sign that they're having difficulty regulating themselves. Maybe a small child who's experienced trauma just starts crying and can't stop crying. Just can't stop, that type of thing. More warning signs. Self-harm. So we know that there's never an appropriate age for self-harm. Self-harming behavior is typically not a suicide attempt, but it's a way of relieving very intense internal pain. Again, it's not to be ignored, right? But it's generally not considered the same. Grandiosity, this is where a person really feels that they may have superpowers, they may feel like they are much more important in the world than maybe they typically are in their particular space that they occupy. Hypervigilance. So this is for an example in a classroom, this is the child who sits at the back of the room in the corner so they can constantly scan. See who's coming in and out of the door, right? Those types of things. Disassociation is a condition where a person literally just kind of disconnects from their mind and body. We see this happen in children and youth who have experienced a lot of abuse, experienced a lot of trauma. They literally just sort of check out. So you might be trying to have a conversation with them, see how they're doing, and they act like they're just not even listening to what you're saying, that kind of thing, because they're disconnecting. Spiteful, defiant, flashbacks, suicidal ideation, hallucinations, which can include all 5 senses. So it's not only hearing voices or seeing things that aren't there, but it's tasting things, smelling things, and feeling things on the skin. So all 5 senses. And then delusional thoughts are thoughts that people have that aren't based in reality. So we teach a class called Understanding Early Episode Psychosis. There's actually 2 of them. There's a version that's for families, and there's a version that's for professionals. So, thanks, Kay. So the class for professionals is really geared toward people who work with youth. And then, of course, the family version is geared more toward this is how you can come alongside and support your loved one who may be living with some type of psychotic spectrum disorder. We have this really good book called Understanding Psychosis on our NAMI website. And I'll share the website at the end. And it is in your handout as well. But this is a really good booklet for families. Doesn't have a lot of clinical content, but it walks through symptoms, medication strategies, those types of things. So it's really good. But if anybody's interested in taking the psychosis class or any of our classes for that matter, we have them all on our website. All right, so now we're going to talk a little bit more in depth about a couple of more specific mental health challenges. So when we see post-traumatic stress, some of those symptoms, for example, recreating the event, absenteeism, which is kind of an avoidance of a situation, really specific changes in behavior, over or underreacting to loud noises. So kind of going back to that student example, if you have a classroom where a student's been subjected to a traumatic event, maybe somebody accidentally knocks a book onto the floor, the student sitting next to that person might kind of go, a little bit of a startled response. This is the student who literally kind of jumps out of their chair, right? They're really, really sensitive to that type of thing. Lower stress tolerance when it comes to emotions, making statements or asking questions about death and dying, so that hopelessness, right? Reoccurring nightmares. So what can cause PTSD? Again, a traumatic event, obviously, right? Post-traumatic stress. So I don't know if anyone in here has ever maybe felt like they've experienced a PTSD symptom of any kind, or even a trauma symptom. So last winter, I got in a car accident. I was on ice, driving on ice. There was a car coming at me this way. I got around the corner, thought, oh, phew, and I'm going 15 miles an hour. I mean, I'm just like white-knuckled. So this car I saw coming at me, but when I got around the corner, I thought, oh, goodness gracious, we escaped, right? We didn't hit each other. Well, this person ended up running into me anyways. And even though he wasn't going very fast, because we were on sheer ice, he couldn't control his vehicle, and my car got totaled from that. And we were going slow. So for months after that, when I would go to get in my car to get groceries or whatever, as soon as I got in the car, my heart would start pounding, my palms would start sweating. You can hear my voice shaking a little bit even, right? Just telling the story, and this was a long time ago. So that can be how it can affect you, right? All right, anxiety. We just heard from Kathy about ways we can manage anxiety, and how might that look in children and youth. Irritability. They may look startled or kind of scared from time to time. It may display as sadness. They may be hypersensitive, have their feelings easily hurt, teary, especially in younger kids, avoiding activities, feeling that fight or flight response, quick to anger. So not being able to manage their emotions, fearful, panicky. My son and his wife took their daughter and her best friend to Valley Fair yesterday. And this little friend is going through a lot at home, really a lot at home, with housing insecurity and all kinds of things. And she usually loves going on rides, loves rides. She got on one of the rides with my granddaughter, and these girls have known each other since they were 2, and they're almost 10, right? So they feel very safe together. But she got on this ride with my granddaughter and literally had a panic attack. They had to pull her off the ride because she couldn't do it. And so that's an example of how, what's going on in a child's life can really affect their anxiety level. Physical complaints, stomach aches, headaches. If you have a youth who's chewing their fingernails down to the nubbins, that can be a sign that they're experiencing a lot of anxiety. Low frustration tolerance. Oh, I'm just not going to do that. I'm not going to be able to do it anyways. That kind of a reaction. And then frequent absences. So again, this would be more like in a school setting, or maybe they're not showing up to their youth group, that type of thing. But we know, as I said earlier, when stress is a challenge, it can be a good thing. But when does it tip over into an anxiety disorder? When it really affects the person's ability to function well, to go to school, to go to work, participate in family activities, those types of things. Depression. So when we're talking about these symptoms of depression, we're talking about symptoms that generally last at least 2 weeks or longer. We know that depression is common from a number of things that can happen to us in our life. Grieving process, if we lose a loved one, something like that. Major life changes can cause us to feel sad or grieving from time to time. What we're referring to here again is a longer period of experiencing these to the point where the typical things we would do to kind of snap ourselves out of those feelings of depression are not working, right? Going for a nice walk with a friend, spending time with family, treating ourselves to a latte, which is my personal favorite. But anyways, so how can that look? So feelings of hopelessness, loss of interest in activities, irritability, especially in men. Irritability can be a sign of depression. Distractibility, more aggressive behavior, excessive guilt, difficulty concentrating. When my mom passed away a couple of years ago, we were very, very close my whole entire life, so it hit hard. And for months after that, I was having trouble remembering things. I was having trouble concentrating, and I knew what it was, right? I knew it was part of the grief process. But again, these things can really affect us cognitively. Problems making decisions. What do I need to get at the grocery store? I don't know. I can't decide. Those types of things. Slow movement, so literally appearing like the person is moving slower. Forgetfulness, and then again, those suicidal thoughts. So NAMI, Minnesota, actually has a class called QPR, which stands for Question, Persuade, Refer. We do several classes pretty much every month, I think, online that people can.
We have at least 2 per month.
At least
that
2.
You can take online.
And
I teach it.
she teaches it, Kay teaches it, so we have an expert here on suicide prevention. I do not teach that class. We have a couple slides in here, as I said earlier, just, for general education, but to really unpack the topic, QPR is outstanding.
And it's an hour and a half.
Mm-hmm.
So it's for the general public, 16 and older. So, general public.
Yeah, but it's quite excellent. But anyway, here's just a couple of warning signs just to be aware of, right? And again, early intervention, talking about death, dying, or suicide, talking about having no reason to live, being a burden to others. So this can also be something that we might see in social media. This might be something that we see in a text message from someone, those types of things. Feeling hopeless, desperate, or trapped, so where they really truly feel like there's no alternative. The situation's not going to get better. Gathering materials to attempt, and correct me if I'm wrong on this, Kay, but my understanding is, especially in youth, the number one means of attempt is Tylenol. Do you know if that's still true? I think it is.
I don't, but I kind of want to give a disclaimer, is that also there's safe messaging about
Mhm.
suicide, so
Mhm.
we're all adults in here. So when we give you information, like the most common means overall for adults is firearms, right?
Mm-hmm.
And it's okay for you to know that information, but we don't talk about details
Mm-hmm.
as safe messaging with suicide prevention. We don't want young people to have a lot of detail. And even when the newscasters tell about there's been a death of someone by suicide, no details. It's certainly okay to say Robin Williams died by suicide, that's fine. We don't give particulars. So you're adults and it's okay for Nancy to tell you that, but yes, medication / over the counter for young people, but overall in the United States it's firearms. And firearms are almost always deadly. So you want to take a class so that you know how to keep people safe. And that doesn't mean you never can have firearms again in your house. It just means during this period of great intense emotional distress, you need to keep restriction of those means, safely from people. That's all.
Yeah, no, thank you for clarifying. And the reason I share that is because if you have a youth that you are concerned about, locking up those prescription medications and Tylenol, yep, is really important to know. And NAMI Minnesota actually has what we call means restriction lock boxes at our office that we're happy to give to people if they want to stop by the office. We're happy to mail them to families. And again, without getting too much in the weeds, because we have this wonderful class that really describes, all the safety measures that families and folks can take, but slowing down that impulsivity by restricting access. Okay. Giving away possessions, especially in youth with this one, what we see is things like gaming consoles, passwords are a big one, and then behaving recklessly. If you have a 17-year-old who usually makes really, really good decisions about things, and all of a sudden you find out that that person was using a parent's car and was going 80 miles an hour down County Road 101 in Minnetonka, that would be behaving recklessly. So just things that are out of the typical scope. And so if you're worried, ask the question. And ask the question directly. It's important to know that asking the question will not plant the idea in their head. So if you're already seeing warning signs, and you're very, very concerned about that individual, you want to ask the question. If they respond yes to the question, there's another series of questions you can ask. And again, we have a whole class around this, but we just want to make sure that people get assistance as quickly as possible, whether that's taking them directly to an emergency department, reaching out to a parent, caregiver, other loved ones, something like that. So again, it's about context and your relationship with the person. Okay, ADHD and ADD. So from a diagnostic perspective, ADHD and ADD used to be diagnosed separately. Now they're actually combined, and they're considered the same disorder, but they're under the ADHD umbrella. So you've got ADHD, which is the primarily hyperactive type, and then the primarily inactive type. But the three main symptoms of ADHD are hyperactivity, impulsivity, and inattention. So again, if we have the kiddo who is wearing their chair in school instead of sitting in it the right way, those types of things.
Wearing your chair.
Wearing your chair. So my youngest son was a very kinetic child, and we wondered at one point if maybe he was having some signs of ADHD, because his teacher would call me and say, Nancy's, Mike's wearing his chair again today. And I'm like, okay, he just literally couldn't sit still. And that's when we got him into sports, and he could kind of work out his wiggles a little bit. He was never diagnosed and did well otherwise. You know, we could focus when he needed to and things like that. But running around, climbing excessively. So this is the child or youth who literally just can't calm themselves down. Okay, Kathy talked a little bit about that this morning. Difficulty waiting or taking turns. Again, this really plays itself out in the classroom. Inattentive symptoms, so just kind of maybe spacey, a little daydreamy, not really focusing when they need to, has trouble paying attention to details and finishing schoolwork. So one of my friends and actually former coworkers at NAMI, lovely young woman, was sharing with me what her experience was like growing up with ADHD. She was diagnosed at 7. Really struggled in school, and we were pretty close friends, so I felt comfortable asking her, would you mind sharing with me how that felt to you? And she said, well, for me having ADHD, she said, imagine walking into a classroom, or any setting for that matter, and everything in the room that you see carries equal weight in your mind. And I thought, wow, that would be so difficult to manage. So for example, when I came into this room today, I looked at where the chairs were, I looked at where I was gonna plug in my laptop, the screen, kind of looked to see where the clock was. You know how you filter out what's important in the moment in your mind, right? Well, can you imagine a child or youth walking into a classroom that's designed to stimulate learning with all the colors and the letters and the numbers hanging from the ceiling and trying to navigate that? If it all carries equal weight in that child's mind, how hard that would be. I just thought that was really, really gave me a ton of perspective, and it also gave me a lot more empathy for people who live with ADHD as well, because I didn't understand it myself. Distractible, tends to appear careless or disorganized, but they may know where everything is, right? Just because we think they're disorganized, maybe they're not necessarily, they might know exactly. But just really having trouble listening and following through on directions. Anybody have any questions or thoughts about this?
Yeah, we're halfway through and you're kind of quiet.
Oh, okay. All right, impulsivity. So the way this can look is, again, blurting out answers before questions have been completed. One of my close family members lives with untreated ADHD as an adult. And there are times when we're trying to have a conversation in a social setting where sometimes it feels like people literally can't finish a sentence because they're constantly being interrupted. And this person isn't trying to be rude or anything. It's just that their mind is going so fast that they're jumping ahead and saying things. So that's where that impulsivity and the interrupting or intruding upon others might be part of it. This can also play itself out in impulsive behaviors. If you have someone who is maybe working on a project, gets about halfway through it, jumps to the next project, gets about halfway through it, jumps to the next project, right? So just really having trouble focusing on one thing at a time. Oppositional defiant disorder. This is a little more rare when it comes to children and youth, but it's out there. And it's actually, I've seen it quite a bit in our clients that come in with psychotic spectrum disorders into the clinic. But this is a condition where they display a pattern of uncooperative, defiant, or hostile behavior. And so this isn't the child that typical disciplinary action or behavior modification will work well for. You're nodding. Do you want to share something about an experience?
So, like, when I was a principal, part of it's like the academic portion, instructional, and then part is behavioral. So, you kind of have what I would say is like repeat offenders, if you will. But over time, you kind of start to see a stark difference between students who are like, maybe they make a mistake, having a bad day, versus this, which it's almost impossible to put things into place to correct the behavior or to redirect the behavior. Almost impossible, which is like in the setting of like a normal campus. So we had something so I'm from Houston, Texas. We had a group of students called the DC students, Discovery Center students. So it's about, let's say like 13 kids who have like a spectrum of different like mood disorders and the ones we're talking about, and this is one of them. And someone had the bright idea to put all of them in the same room. So what happens is it was just complete chaos. So what would happen is they would just fight 2 or 3 times a day, destroy the entire room. We'd be running, we'd have to break up these fights, we'd separate them, and it would just repeat over and over and over again. And it's like no matter what we put into place, it just wouldn't stick. And a lot of those students we had to refer to different like campuses that would give them more specialized support and care and structure that would allow them to function, because otherwise it just wouldn't work. Like we couldn't put them in an inclusive environment in a regular like classroom with other students, because then what would happen is they would just keep going back and forth with teachers and other students, and no learning could happen in those like, environments. It was very scary actually, because it's like, what do we do? And most, I would say like at least down south, most high schools, middle schools are not equipped to deal with this, and then there's a lot of students who are also not diagnosed with it. So it's like we're just assuming they might be, we're not sure, so we don't know how to proceed sometimes. And it's kind of scary actually.
I have a question,
We should be doing the mic.
does it stand alone in most cases? Because these sound like things that could also be symptoms. Is this?
There's a microphone in there.
Oh, do we need it?
Sure.
Oh.
Because we're taking.
We're recording.
Oh, okay, I was like,
I should
I'm
have done that
thinking
much
pretty loud.
earlier, and I was like, oh my
Well, my
goodness, I
question
forgot the
is-
box.
How often does this stand alone, or how many of those could also be symptoms of traumatic stress disorder or whatever else is going on? The other things that you bring, or so they paired, or how does that? Do you
So-
understand my question? Like when I look at those, I think of those as very similar to the PTSD slide symptoms. So
Mhm.
how I guess you have to dig down and figure out is this a symptom of a larger situation? Does that
Right.
make sense?
So, well, in order to get a diagnosis, they have to exhibit symptoms for at least 6 months
Mm-hmm.
to be actually diagnosed with ODD. We know it's normal for some kids to be defiant from
Right.
time to time. But this is where they're literally defiant like all the time.
All the time, but
Any type of authority, whereas with PTSD, we see more of an anxiety mix
Mm-hmm.
in there. But yeah, I can't even imagine from an education perspective how difficult it would be to try to manage a classroom with multiple students with this, because it's like there's the wiring in the brain is such that they literally can't.
Right, but I'm just wondering what's
correct,
beneath that,
self-correct.
I
Are you
guess.
asking also, could you have multiple?
Sure,
things?
yeah, I know that you
Oh,
can, I'm
yeah.
just wondering if there's something deeper beneath that, because most behaviors are coming from somewhere, that iceberg that you showed.
Mhm.
So I'm just wondering if a piece of the ODD is driven by some of the other
Mhm.
diagnosis or the overlapping issues. Does that
Could be,
make sense?
yeah,
Possible?
absolutely. We see multiple occurring mental
Mhm.
illnesses with people. Absolutely.
It's kind of a good question for a clinician.
Yeah.
It
If
is.
you
It's
have
a
ch-
clinical
if you have a
question.
No,
chance-
I'm just curious,
No, but-
how much ODD stands on its own as just this one thing.
I
It
mean, I
just
think
seems
it's like-
very likely that something else is going
I
on.
mean, it's a good question, so if you have a chance to
Yeah.
talk to a pediatrician or talk to, a child psychiatrist, that's a great question.
Yeah, just out of,
Yeah.
just intellectual curiosity.
No, that's a great question, though. Thank you for asking it. Yes.
Do
You want to
these-
throw her the box?
Oh, sorry.
Okay. Do these things often run in families? Like, is there a genetic component to, like, could the parents or the grandparents have had this too, and it just wasn't brought to anyone's attention?
Sure. Yeah, and there's certain mental illnesses that are more inheritable than others.
And what are they?
Typically, mood disorders.
Okay.
ADHD is highly inheritable. Bipolar disorder is highly inheritable and tends to run in families.
Okay.
And
There-
anxiety also,
And anxiety, yeah.
schizophrenia.
There's a genetic component to it, but from a statistical perspective, because we talked about this as a family, because I shared my oldest son has schizophrenia. And at the time when he was diagnosed almost 20 years ago, at that point the knowledge was the chances of his younger brother developing it was like 6%. It was pretty low. If you have somebody who lives with the disorder and has a child, then that percentage goes up. definitely goes up. Yeah.
I just read a book about a family that had 12 children. They're still living, some of them, and 6 of them had schizophrenia.
It's rare. That's an
Yeah.
unusual book.
It's
And
a
I
family
know,
in
I can't think of the name of it, I've heard of it,
It's a
but,
family in Colorado.
yeah.
But they learned a lot about schizophrenia by studying this family. And I mean, the knowledge of schizophrenia obviously has changed a lot in the past 50 years.
Sure.
But the oldest son, who was the first who got it, is still alive. And he thinks his dad is an octopus, which is, that is the thing that just gets me.
Distortion of reality.
And he really does. He's, you know, like a 70-some-year-old man, and he thinks his dad's an octopus. So it's something that we normal people, quote unquote normal people, can't relate to, or,
Yeah.
you know,
It's remarkably complicated.
it's so.
And the class that we teach, both the classes for families and professionals, is almost a solid 2 hours just on psychosis. It's a very complicated
Yeah.
set of symptoms and treatments and all the things. So, yeah, thank you for sharing that. Yeah. I'm really curious about this now. I feel like I'm going to go back to the office and figure it out. All right. Speaking of psychosis, here we go. All right, so who gets psychosis? So we're thinking about a set of symptoms, right, that comprise psychosis. Up to about 6% of the population is going to potentially experience symptoms at some point or another. This percentage has gone up over the last few years since the legalization of cannabis. I don't have that current statistic right now. The numbers are going off the charts, though, I can tell you that. It's found in all cultures, affects males and females fairly equally. What I can tell you about the age of onset is that young men tend to experience symptoms a little bit younger than young women, maybe late teens, early 20s. Young women tend to develop psychotic spectrum disorders a little closer to the mid-20s. What research has shown is that estrogen is actually a protective factor in the brain, which they think might explain the difference. But if you are interacting with someone who's having symptoms, and again, really excellent booklet for people to use as a resource, having difficulty paying attention. Now imagine you're hearing voices. Can't even imagine that, how that would feel, right? And you're trying to have a conversation with someone. So you've literally got at least 2 people talking to you. When my son isn't doing well, he hears multiple voices at once. And there's times when I'll try to talk to him when he's not doing well and he just completely glazes over because he can't focus. He describes it as feeling like he's listening to a radio, but it's between 2 stations and neither station is really coming in clear.
What are these voices they hear? I mean, I don't understand voices. What is that?
So it's quite literally like they're hearing someone talking in their head, but it sounds like someone is talking out loud to them, just like I'm talking to you right now. And usually the voices are saying things that aren't kind, which is the other problem. Not always, but quite often. Yeah. So anyway, making it much more difficult for them to just understand, communicate. When we talked about hallucinations affecting all 5 senses, so seeing things that aren't there, feeling things that aren't there, tasting things, smelling things. So an overall disconnection from reality. So you can only imagine how stressful that would be and how difficult that would be to manage. And so some of the main things that we see, especially in teens and young adults, is avoidance, right? They might start really isolating, not going to school, not going to work, avoiding family and friends, because it's literally taking everything they have psychologically and emotionally to manage the symptoms that they're having, which are typically quite terrifying, honestly. Very scary stuff, right? But a lot of avoidance. They also may really stop taking care of themselves. One of the things that happens quite often is they stop showering. They might stop changing clothes and just taking care of themselves physically. They might stop eating. They might stop drinking if they're feeling paranoid about food. those types of things. And again, I can fill 2 hours with this stuff, so we'll make this fairly quick. But having odd beliefs, so that really is kind of referring more to what we call delusional thoughts, which are thoughts that are not based in reality. So very quickly, when my son started having symptoms in middle school, it was when Lord of the Rings was really popular, The Hobbit, all those things. And being the creative guy that he was at the time also, he carved this really beautiful walking stick. Carved it, stained it, varnished it, took him everywhere he went. He had his walking stick with him. He came home from school one day and told us that he thought he could control the weather with his walking stick. And there's nothing we could have said to have moved him off that thought, because that was his truth in the moment. So we never want to argue with someone who's having delusional thoughts, because it will just create a more difficult situation. Acting as if they're suspicious of you, again, this is where some of that paranoia can come in. Using odd word combinations, being unexpectedly aggressive, laughing inappropriately, feeling paranoid. Sometimes if a person, getting back to this aggressive piece really quickly, we know that statistically most people who live with severe mental illnesses isolate. They don't go out into the community and commit violent acts because they just can't be out around people. But sometimes if a person is really struggling with voices, they may do something to try to make the voices stop, like punching a wall or hitting their head on something or something like that. But yeah, and the feelings of paranoia. When we see paranoia in teens and young adults, quite often this manifests as it relates to their electronics. They may feel like they're being monitored through their laptop. They may feel like someone's listening in on their conversations over their cell phone, and so they will throw their electronics in the garbage can. So what do we do if we're interacting with youth and we think they might be experiencing symptoms of psychosis? This, again, can really there's a whole de-escalation technique that we want to use if we are interacting with someone who is truly having these symptoms. But again, context of relationship, right? Talking with the person in a very calm, non-judgmental way, letting them know that we're concerned. The early treatment, again, is incredibly important. The longer a person goes with untreated psychosis, the harder it is to recover. And then referring the person to a counselor, mental health professional. So part of what I do is I'm a family peer for what we call the Navigate teams here in the metro area, and those are mental health teams that are actually geared toward serving teens and youth who live with symptoms of psychosis, helping them get back to work, get back to school, all those different things. So when we're thinking about the fact that mental illnesses are usually driven by brain chemistry disruptions, right? Quite often the first line of defense is medication. There's several things that can work wonderfully well for people to manage their mental health challenges, such as therapy, being mindful of diet, exercise, yoga, a person's faith walk. All these things can really contribute to mental health in a very positive way. But if a person is experiencing such severe anxiety or depression or symptoms of psychosis, their brain chemistry is not balanced properly. And so it's going to make it really difficult for any of these other things to work well. So quite often medication is the first line of defense. Some of the side effects that we might see a person experiencing or experience ourselves if we're having a mental health challenge are just feeling really medicated and sleepy. Dry mouth, dizziness, constipation, weight gain or loss. Weight gain, especially with antipsychotic medications, is a big side effect. Feeling more edgy, more nervous, kind of shaky, maybe some confusion, maybe some headaches, stomach aches, those types of things. So we just really encourage people to work very closely with their prescriber, whether they're getting medication through a primary care physician, if they are seeing an actual psychiatrist for their medication needs, but to just communicate that, because the goal of providers is to have a dose that helps the person, a therapeutic level, that helps the symptoms be under control, but the least amount of side effects. So if, let's say you have a teen who starts on ADHD medication and they're literally not able to eat. They just can't eat at all. They have no appetite whatsoever. Well, that's not safe. We don't want that to happen, right? So just really encouraging people to have those open and honest conversations with their doctors. Substance use, again, a ginormous topic. I have one slide. What we're going to do is talk about the complexities that happen, however, when we have a youth who starts using substances to sort of medicate their symptoms, okay? It really creates what we call a chicken and egg situation diagnostically. Let's say we have a youth who starts smoking a lot of marijuana, they're using a lot of cannabis. We know that cannabis causes anxiety in the long term. Really, really makes it much, much worse. But for someone who's using that product, ingesting THC products, it may make them feel relaxed in the moment, because I've heard this 500 times. Oh, it helps my anxiety. You know what? Wait 2 days and tell me how you feel. Because once it starts working out of their system, it makes the anxiety worse. Let's say a caregiver goes to take their youth, their teen, whomever, for an assessment because they're worried about substance use. Maybe they're worried about anxiety and depression, or maybe even symptoms of psychosis. And the provider might say, well, what did they start experiencing first? Were they using first? Or were they having symptoms first? And then you get into this chicken and egg situation, and it makes it much more difficult to diagnose. One of the things that we're seeing, which could be a whole separate class, I think, is just the impact that cannabis is having on our teens and young adults. We know that it really damages the developing teenage brain, and that actually could be a completely separate class. But we're seeing symptoms of psychosis related to THC use skyrocket. So, and the problem is, you know, these teens and young adults, they don't know what their set point is. They don't know what the threshold is. So you might have one person who can use THC products, whether it's a teen or an adult, and it doesn't really affect them very much, except maybe the desired effect, but they don't have symptoms of psychosis. And then you might have another person who just becomes floridly psychotic with one use. And what we're also seeing is because the levels of THC are so high in marijuana right now, and this is not a statement, by the way, on medical marijuana at all, okay? This is recreational use. That what we're seeing more often than not is they may start having initial symptoms of psychosis, which is what happened to my son. And they may say, okay, if we know the person's using THC, let's wait 30 days, encourage them to abstain from using, and see if the symptoms resolve on their own once that THC wears out of their system. What we're seeing now, because the levels are so high, is that more often than not, it converts directly into a mood disorder or thought disorder. So it's, yeah, it's kind of scary stuff.
You can't trust the safety of the drug you're getting either, you know,
Right.
if you're getting it on, well, even if you're getting it in a, you know,
A dispensary.
Yeah.
but if you're buying it on the street, you know, it's not like in the 60s when I, you know, grew up, it's nothing like that. And
Right.
it's very, very, very scary.
Yeah, yeah. So NAMI is an organization that does a lot of education in high schools and middle schools around mental health, and we touch on this in those presentations just so students are aware, because the response is, well, it's legal now. Why can't I do it? It's legal now. And it's like, well, but buddy, you don't know how it's going to affect you, right? And so anyway, we're doing our best as an organization to try to keep kids and teens safe, but it's a whole issue. NAMI also has a co-occurring disorders booklet. It's fairly new. I don't have one with me, I don't think. But it came out, I think we published it within the last year.
Well, 2 years.
2 years, yeah. And a lot of hard work went into developing that booklet. So it might be really helpful for folks to have that. So how can we help? What can we do? So when it comes to children, youth, again, younger kiddos just might not have the vocabulary to describe how they're feeling and explain to us what's going on. And so starting with our own feelings, and this actually relates to anyone that we're having the conversation with. This is a difficult conversation to have with anyone if you're seeing symptoms and you're concerned about them. Validating their feelings, because this can be very scary, right, to start having these symptoms. Be open about your own mental health. And especially with teenagers, I like this last bullet, leave the door open, but don't shove them through it. So anybody who's had a teenager, works with a teenager, knows a teenager, knows that you can plant a seed for a conversation. They may not be ready to talk about it. They may need to think about it. They may need to bring it up on their own. But the point of this is really just to create a partnership, and to have that person know that there are safe people out there that they can chat with if they have concerns about themselves or someone else, or a loved one or friend, family member. And then reminding them of trusted adults. So what we hear sometimes is that students don't necessarily want to confide or share with parents or caregivers because they're afraid maybe that the parents will become really worried about them. And I hear that a lot from students. So part of our conversation that we have with students when we go into the high schools and middle schools is to remind them of the trusted adults in their lives, the other people that they can talk with, whether it's a neighbor, a grandparent, aunt, uncle, cousins, teachers, school nurse, somebody in their faith community. But just making sure that they know that they have somebody that they can reach out to just tell one person can make all the difference. And then just thinking about professionals that can help. So quite often when I'm working with families, parents might have a child that they're very concerned about, but they don't really know where to start. And we know that the mental health system is very complicated. We know that there's a shortage of providers available to folks. Sometimes if a family's trying to find a therapist, they might be told there's a 2 to 3 month wait at least to get into somebody in their area. So quite often just going to the child's pediatrician or a primary doctor, primary care physician, can be a really great place to start, right? Because it's always good to rule out any kind of physical cause, right? So if the person's experiencing symptoms of depression, especially at this time of year when the days are getting shorter, maybe they're having some of that seasonal affective disorder type of reaction, getting a blood workup to find out what their vitamin D level is, right? Do they need to take supplements? Just, those types of things. So starting with a primary can be really, really helpful. They can also make referrals in the mental health system. Seeing a therapist, as we mentioned, can be wonderfully supportive. The 988 Suicide and Crisis Lifeline, this used to be the National Suicide Prevention Hotline. This has been on the news a lot. It was advertised quite a bit when they were first rolling it out. But all you have to do is hit 988 on your phone, and there's mental health professionals that can help walk you through situations. So whether you have a concern for yourself, whether you have a concern for a loved one or a student, there's somebody on the other end of the line that can walk you through what to do next. We also have this sheet. Actually, it was shown at the very beginning of the day this morning. It's a two-sided sheet with crisis and non-crisis resources on it. This is at the NAMI table that's out in the main area. So feel free to grab one of these. NAMI has a class called Managing a Mental Health Crisis. We have one for families, we have one for adults. And again, that's a 90-minute class where we really walk through how to recognize if you have a loved one or someone that you're working with that's having a mental health crisis and what to do. When do you call 911? When do you call your county crisis team? Because there's ways to do it that are helpful and there's ways to do it that aren't so helpful. But that can be a whole nother class, and de-escalation techniques as well. But you can call 988 just to talk with someone, just to get an opinion, share your concerns, and then they can help guide you. They can also connect you directly to your mental health crisis team in your county. So whether it's for an adult or for a child, they can connect you directly. So when do we call 911 and when do we call our county mental health crisis team? Very quickly. It really depends on the severity of the situation. Sometimes it can take a long time for mental health crisis team to get to school, get to a home, get to wherever the crisis might be happening. Might be an hour, might be 2 hours. So if the person is in imminent danger, if they have a weapon, if they're bleeding, if you're concerned for their immediate safety, that's when you call 911. You ask to speak to a CIT trained officer. That's a crisis intervention trained officer. And these folks are trained to manage these types of situations. Yes?
1 minute.
Yes, please.
Oh, just 1 minute, yeah.
Oh, I have 1 minute left? Oh, I thought you were going to share. This woman has so much knowledge in this brain. How long have you worked for NAMI? How many years?
15 years.
15 years. So she's got twice the time on me. But okay. But anyways, so again, we have a whole class around this, and we also have a booklet called Managing a Crisis as well that's available. As far as community resources go, and these are on the last page of your handout, Fast Tracker Minnesota is a really great website for finding insurance providers. You can sort by zip code, who your insurance provider is, and what the specialty is you're looking for.
They're here today in the resource center,
Mhm.
the Fast Track.
It's really great. It saves families a lot of time. And then, of course, if you go to our NAMI Minnesota website, all of our booklets are online as PDFs. We're also happy to mail them to people's homes and provide them to educators. Yep. We have a number of support groups that are available to folks as well. We have one for parents and caregivers for youth under 21. We have a couple of those. We have many family support groups. We have 3 support groups for families who have loved ones living with psychosis. So a lot of support for folks who have loved ones who live with mental illnesses and also individuals themselves. We also have the Parent Warm Line, and this is for folks who have kiddos who are 21 and under. And then NAMI Minnesota also has our helpline, which is for anybody, can call into that helpline if you have a concern about a loved one, about yourself, if you're looking for resources in the community, for a school, whatever it might be. We have a team of people that just answers our helpline, and they're wonderfully helpful. They're great. So I know we're at time, so sorry I went over a couple minutes there, but yeah.
Well, thank you, Nancy, really appreciate it.
Thank you, everybody.
And
Hope you have a good rest of your day.
Lunch is 2 floors down in Linda Hall, and then lunch then is followed by another whole set of breakouts. So if you have any questions, want to get someplace to see me.
And again, you've got our website on your handout. Lots of resources. Thank you so much. Hope you guys have a good rest of your day.
Yeah, we just have, you're welcome to this one.